Good morning, everyone, and welcome to this open session entitled COVID-19 Lessons Learned, which is part of our Taiwan Nordic Forum 2021. I guess the very fact that we're holding this panel on Zoom today already speaks volumes. We are living in a global pandemic, which has upended many things that we once took for granted and which is impacting all aspects of our lives. We're slowly seeing some light at the end of the tunnel now that a vaccine is available, but there are so many questions that are still unanswered. And since we all have very different experiences in dealing with the COVID-19 pandemic, it is worthwhile to take a step back and to reassess the situation. If anything, this pandemic has shown us that sharing insights and experiences is key to understanding and confronting pandemics in the future. And for this very reason, we are very honored that we have 4 distinguished guests joining us today to shed light on these intricacies of public health policy amidst an ongoing pandemic. First off, we have Therese Sefton, who is a research assistant with the Peace Research Institute in Oslo, Norway. She's currently part of the research project Disparate Responses to the COVID-19 pandemic in Norway and Sweden, Lessons and Opportunities for the Nordic region. Second, we have Professor Tove Fall, who is a Professor of Molecular Epidemiology at Uppsala University and is one of the research leaders in the COVID Symptom Study and the interdisciplinary CRUSH COVID study. Then we have Professor Runólfur Pálsson, who is a professor at the Faculty of Medicine at the University of Iceland. He is also the director of the Department of Internal Medicine and Rehabilitation Services at Landspitali, the National University Hospital of Iceland. He is the co-author of a population-based cohort study on COVID-19 symptoms. And lastly, we have in Taiwan, Dr. Chun-Chien Kuo, who is a professor at the National Taipei University of Business. And in 2020, he published a paper on Taiwan's pandemic response and lessons learned. So without further ado, I would like to give the floor to Dr. Chun-Chien Kuo to tell us more about Taiwan's response.
Thank you. Thank you. Can you hear me?
Yes, we can, but now you're muted. Dr. Kuo, you're muted.
Now
we can hear you, yes.
Now, okay. You can respect chair, speaker, and participants. My name is Chun-Chien Kuo from Taiwan, and it's my great honor to be invited to attend this interesting webinar and to discuss the important issue about COVID-19 lesson learned. Taiwan has been appraised for its well performance in fighting against COVID-19. And when the pandemic began last year, January, from Wuhan, China, at that time, many experts, they expect Taiwan will be hit badly by the virus because it's distance very close to China and it's close economic linkage with China. So that's at that time the situation looks bad. However, as time passes, and Taiwan has been managed the COVID-19 threat right well. And today we only have in the 23 million population in Taiwan, we only have 955 cases, infected cases, and only have 9 deaths. And in fact, as you see, Taiwan people now are so lucky. We can enjoy a near normal life, and we don't need to suffer some things like the close of school, working place, and which occurs around many countries because lockdown. Taiwan, we don't have lockdown, so we are kind of lucky. And what did Taiwan do? Government do? How can we just be so lucky? There are some factors I mentioned in my paper last year. And so first, let me show you, despite the COVID-19 threat, and Taiwan economy has marked down a very impressive 2.54, a positive economic growth rate in 2020s. And actually in this year, 2021, Taiwan, the economic growth rate is predict even higher growth rate, around 4%. And so, in other words, Taiwan economy was not dragged down too much by the COVID-19 threat for the past years. And of course, there are some factors help this success. For example, including the early setting up for the central command center and very tight border control, strict quarantine policy, and good public health awareness. People are used to wearing face masks and washing hands frequently. And besides, they are utilizing the technology to fight COVID-19 and on the existing wide coverage national health insurance program. And the most importantly, in my personal view, is the 2003 SARS experience that to help. In 17 years ago, Taiwan was suffered by the SARS, and we learned the lessons. So the 23 SARS experience is quite a key point for Taiwan's fighting against COVID-19 this time. It not only helped Taiwan people live in Taiwan more collaborative, more obedient to some essential hygienic requirements, such as wearing face masks all the time when taking public transportation or maintain proper social distancing. And not only that, but also push the government, the administration to be more alert and cautious response when the COVID-19 outbreak begins. The government was respond quite quickly, which I call in my paper, deploy in advance attitude. What I mean deploy in advance is we make all the possible preparation even before things happens, or we predict it will happen or not happen. So in fact, I can say this time Taiwan was lucky enough. We have accumulated the experience 17 years ago, and we prepared for a while. And thanks God, this time works very well. And so far, Taiwan is doing quite good. One point I want to mention about it: Taiwan is an island surrounded by by oceans. So we don't have without any land border with other countries. So to enforce the border control is quite easier for Taiwan because we can just stop the flight from entering into the island, and that's easy. But as you know, Taiwan economy is famous, doing quite well in the certain electronic products or ICT technology. And this time we utilize this technology and apply on the existing wide coverage national health program and to help do the quarantine policy or help to distribute the medical equipment like face mask. For example, in the beginning of time, people was rushing to buy face mask. They are panicked. They are not shortage for the face mask. And the government just gathering all the domestic producers and to form a national face mask team to increase production and to add more production line. But also they're using the insurance card for the national insurance system, and people can apply their card to neighborhood convenience store, drugstore to buy a very cheap face mask. Say maybe in the beginning, 5 face masks per 10 days, and not later extend to 9 and 10, and at very cheap price, maybe 0.1 European dollars per mask. And after that helped people to cease the panic and also let people become more competent. I think that's very important, the technology we use. And so that's the lesson, Taiwan. I think I want to summarize my lesson is the quick response for governments and more cooperative public attitude. Taiwan people live in Taiwan, they are used to wearing face masks. One, because of SARS experience, sometimes because the Asian countries are used to do, not like other countries, they culturally, they don't like to wear face masks. So we are easier to do this. Okay, so that's the lesson I think I want to show. And I want to mention one more thing is the government intervention is quite crucial, quite important. In the beginning stage, Taiwan government will intervene the production for hygienic use alcohol, face masks, and even we produce more face masks, we spend help other countries. And that helps because in the beginning, when you face in a crisis, the beginning stage to seize the panic, to smooth people's uncertainty, and that helps we can fight together easily with government and to face the crisis. So I think that's something I mentioned in my paper. How much time do I still have? 5 minutes, 2 minutes?
You can still go on for a few minutes, that's fine.
Okay. So if time allows, I want to mention, based on this fighting COVID-19 experience, there are some opportunities and also some challenge for Taiwan. The first one, as you know, Taiwan was excluded from WHO, and that really bad. And I hope this success experience for Taiwan fighting COVID-19 this time can give us some help to help Taiwan to return or to come back to WHO. If not, I mentioned in my paper, maybe there are some new regarding public health, new international coalition can put Taiwan in, because the virus cannot choose countries. We cannot, the world just simply cannot ignore the contribution for Taiwan. So hopefully this can some opportunity for Taiwan to be able to return to WHO or related public health coalition, international coalition. That's mine. And also they produce some opportunity for Taiwan. And this time, Taiwan's technology, some manufacturer producer in 5G, in big data, and semiconductors, because of COVID-19, we may have readjust our production, and hopefully in the new shuffle for the global supply chain, Taiwan can gain a better position for further economic prosperity in the future. And that's a good signs for this. But also there are some challenges we're facing. The first challenge is a possible second wave outbreak in Taiwan. Since last year, the second half of last year, Taiwan had no community infected cases. So the people's awareness was loosened. And we saw a lot of revenge traveling in our country. We cannot take flight to abroad, but people crowded and without wearing face masks. And I was worried about a second outbreak happen. Thank God, so far we don't have an outbreak happening, and that's good. And except last month there's a hospital in Taoyuan, possible community infection, but now the situation is over. So there's no community infected case happening in Taiwan. So that's very lucky for Taiwan. The second one is the challenge is an old one, the relation between Taiwan and China. That's all issue, but it's very complicated, hard to solve. And I will say the tension between Taiwan and China has been getting new height since 2016 President Tsai's inauguration. And the conflict between Taiwan and China is getting more serious, especially after the US-China trade war. And so hopefully this situation can get some improvement, the new US administration, Biden administration, and hopefully the cross-strait can start to talk again and can cease some conflict. If this situation do not stop, and that's bad, that will create more uncertainty for Taiwan's economy. For example, this week, China just stop importing the pineapple from Taiwan. So since we'll get worse and worse, this is not good for the economy. But anyway, nothing Taiwan can do now. We can just adjust our production and find more export, whatever. But the all issues about Taiwan-China relationship is still a very big challenge for Taiwan. And the last challenge is the vaccine problem. Taiwan was ranking in the Bloomberg ranking about fighting COVID-19 performance, was ranking second or third in last November. But now it dropped to 7th place. I think the reason is because first, in last January, Taiwan's death case jumped from 7 to 9. The percentage increased a lot, so that hurts. But I think the more important is the vaccine problem. Taiwan now only do not get enough vaccine for our residents. We only can, at the most, we can get about 37% to be due. Thank God, this morning there's some vaccine from AZ just arrived to Taipei airport, but no one in Taiwan has been vaccinated. So that's the difficulty for Taiwan. Hopefully, in the coming months, as the vaccine become more available, Taiwan can get more vaccine, and the economy and people can get vaccinated, and the problem will solve. Okay, that's probably the experience I want to share with the audience, the participants. And thank you for your listening. You are welcome to ask me questions. But I'm not an expert for the diplomatic China-Taiwan relation. But maybe some question I will not answer because I don't know too much. I'm an economist. Thank you.
Thank you very much, Dr. Chun-Chien Kuo. That was very insightful, and I'm pretty sure that you will be able to answer most questions regardless. I would like to now give the floor to Therese Sefton.
Hi, everyone. Do you hear me?
Yes, we hear you.
Okay, thank you. So my name is Therese, and I'm very delighted to participate in this webinar and with all these great other panelists and hopefully interested public. So thank you first. So I work at PRIO, the Peace Research Institute in Oslo, but also with UIO, the University of Oslo. We have a twin project that we're trying to develop further here. So my focus is on Nordic cooperation, Nordic relations, but mostly Norway and Sweden. I've been looking at what perplexed me the most when the pandemic came to the Nordic region was I had an expectation of Sweden sort of leading the way in crisis management and handling this pandemic relatively in the same manner as the other countries would do. And I think that's the thing that perplexed us, the observers most, that we didn't count on things being so radically different. And in that sense, it made an interesting case to look at both Norway and Sweden and try to nest out why these differences occurs. And in order to talk about lessons learned, I think we have to take one step back and look at, okay, how did these approaches to crisis management develop, and what were they? So I have one pillar that's the objectives of the strategies, and in Norway it's always been talk about to stop the spread and eliminate the virus. And in Sweden, it's been more of a focus on a slow spread to prevent overburdening of the hospitals and in the healthcare sector in general. And these are again based on and have been motivated by something called dugnad in Norway. It's that you as a people participate in accepting the measures that are taken to stop and eliminate the virus. And in Sweden, it's been more of a folkvett. In the initial phase of the pandemic, people talked about folkvett, and my understanding of folkvett is okay, we as individuals have our responsibilities and common sense to understand what our responsibilities are. So on an accumulated level, this will be fine because most people understand what's expected of us. But also in Sweden was a belief that the healthcare system is sustainable. And that's very interesting because in 2019, doctors and nurses in Stockholm region started to demonstrate because they had so much to do. They were the way to organize personnel and the healthcare system was not sustainable for the people who actually worked there. So there was an overcapacity, at least at Södersjukhuset. And to have a strategy where you will give the healthcare system, how can I express myself here? To know that the healthcare system will get much more to do, while also not starting off on a great point is very surprising. Then that they believe that we have a sustainable system. And one other difference is the influence of authorities. In Sweden, I recognized that it was Folkhälsomyndigheten, at first the general director, but later also the state epidemiologist and the other from MSB and other relevant authorities who started to do these press conferences. But as I understood it, it was clear that Folkhälsomyndigheten, the public health authority, wanted to have influence over the decision-making process, not the process itself, but the decisions that the politicians were supposed to implement in order to slow the spread of the virus. So as you can hear, I'm mainly talking about the initial phase because that's where the measures between Norway and Sweden differs most. And in Norway, you have two authorities, but you have also the ministries, the cabinets. They can. There's been a more three-way dialogue and decision-making process between the Minister of Health and Care, the Prime Minister, and the Minister of Justice, also in a dialogue with the two public health institutions in Norway, FHI and the Norwegian Directorate of Health. So there's been more, seemingly, it's been more compromises between these three entities, where the government did not hesitate to implement a precautionary principle in every decision they made. And one other big difference, I believe, and I've been watching every press conference and with the ministers and with the governments, and not every with the public health authority in Sweden, but a lot of them, and that is the communication. In Norway, it's been fairly straightforward that this virus, it is a threat and we need to come together to eliminate this. And they are, well, in Sweden, it seems that an important part of the communication was not to downplay the risks, but not to spread fear and not to create a sense of really deep urgency among the public, because that can have fairly negative consequences too. But in Norway, they were very clear from day one that this is not something we are going to take easy. We will do what is necessary to do. And just yesterday, that message was reiterated again, in fear of a third wave here by the Minister of Health and Care. And it's when they have spoken about folkvett or individual responsibilities and what recommendations and rules, and it's been very ambiguous and very hard to interpret what my responsibilities as an individual has been. It leaves a lot of leeway to interpret it in an arbitrary way, and that's been a huge difference. But I want to make clear that that's been a debated thing here in Norway too, where we didn't understand exactly what we could do or what we're allowed to do, and so on. I even had to call the municipality once because my daughter's birthday, and I didn't know if I could invite the people in her daycare group, or how was it to, because just one example to show that communication is hard everywhere in these situations, but overall I think they've been pretty straightforward. Then we have my perhaps the most challenging part when it comes to Nordic cooperation is the borders, and the difference there was that Sweden remained open for a long time, but issued travel advice and warnings. But in Norway and the other Nordic countries, they choose to close in varying degrees and durations. But Norway also issued quarantine measures very early and a ban on traveling abroad for healthcare personnel in the initial phase, in order to make sure that all eventual essential personnel were available. And most of the countries' measures have been designed as isolation strategies aimed at avoiding each other, which is classic border control incentive, and was expected in terms of filtering the movement of people across borders. But this started in 2015 already, with when we had the huge influx of migrants in Sweden and Europe. So it's nothing new, and when it's been done once, it's fairly easy to implement these measures again. But the way Sweden handled the pandemic during the first wave and sort of let the virus spread, the societal spread of the virus, they became perceived of as a threat as much as the virus itself, which is also classic as an incentive to close the borders. You have to have the other, and something or someone has to be a threat for you to close the borders. And then it was fairly easy, given the situation and given all the criticism Sweden actually got from other countries, and how the surprising approach for a lot of us. It was fairly understandable that we will only open to some regions where the infection rates are at this level or that level, and so on. So that's been, I think, the perception of Swedes who might have the virus has been it's taken a toll on the relationship between Norway and Sweden. And I'm Swedish myself and live here in Norway since 13 years. So it's kind of interesting to hear what other people think. And I spoke with one researcher in Gothenburg, and her husband works on an oil rig in Norway, and he said that he was given a Swedish bag, and it was these face masks and antibac. And I don't know if it was a prank, but it said something about the perception of the other. Because when countries started to open up the borders, we expected kind of the Nordic region to create their own travel bubble. So that was kind of interesting what happened there. And I thought about what might make these countries unique. And I mean, Norway has been relatively spared in relation to number of infections and deaths, but also in relation to this pressure on the healthcare institutions, who have actually been able to carry on with daily works and screenings and necessary healthcare provision. And Sweden's crisis management is unique in the sense that their strategy initially was based on certain expertise where the political influence was fairly limited. And we have to understand that a pandemic, it needs a national response. It needs a holistic response, I believe, because it's not only about numbers of rates of infection. It's about how we move. It's about how we understand rules and recommendation. It's about so much more than just it's behavior. And it's sometimes people need incentives not to do something. And if that needs to be a rule or a law, sometimes that's like say you can't have a party with 50 people now. That's just not okay. And when that happened in Norway, and when that happened, you could see actually small clusters of the virus spread between these people and their families and people they had met. It may sound controversial, but that was maybe unique for Sweden, that it didn't seem like a holistic approach. And lessons learned is the consequences, of course, is that perhaps you are familiar with the Nordic Council, who aspire to make the Nordic region the most integrated region in the world by 2030. And the pandemic has proven to maybe be a challenge to achieve this goal. And it has in fact also created a kind of a double crisis. And what we mean when we talk about the double crisis in this sense refers to not only mutual political frustration over closed borders, travel restrictions, and diametrically different paths in crisis management. It also refers to actually these physical borders that are now implemented, and I can't see my family in Sweden now. I've seen them once in a year. And the further away we get from each other, the worse it's going to be to cooperate. And we've seen how some of us may have heard how a lot of people who live in the border regions are deeply and affected by this, who can't come to work, who where it's unclear what if Norway or Sweden will compensate them for the loss of work. Now workers who commute on a day-by-day basis, they can come, but people who commute on a weekly basis can't, are not allowed to come to work. So we have the contrast between Sweden's and Norway's management of the pandemic based on objectives, influence of authorities, communication, testing, tracing, and isolating, and border control have created a double crisis with potential long-term consequences for Nordic cooperation and the idea of the Nordic region being the most integrated in the world by 2030. Yes, is that maybe, do I have some more minutes?
I would like you to wrap up, actually.
Yeah, oh, that's great. I just wrapped up.
Good, thank you. Thank you so much, Therese, for this very interesting presentation. I'm pretty sure that we're going to have more time during the Q&A to talk about different aspects. I would like to invite Professor Fall now to present.
See, do you hear me?
Yes, we can hear you.
Yeah, I was just trying to put on the my video as well if you want to see me. Let's see, can you see my slideshow? Do you see my slideshow now?
Yes, we can see your slideshow, but you're not having a full screen.
Okay. Trying once more. Let's see. So in the meanwhile, I just want to thank you for the invitation. I think it's extremely interesting to hear about the experiences from the different countries. Do you see my full screen now?
We can see your notes. I mean, you don't have any notes, it seems, but it's not full screen, but I think it works still.
Okay, I'll just do a last attempt and then I will, if not, let's see. It went well when we practiced, but now it seems harder. Let's do it like this then, that you see my, now you see just my, okay. So apologies for showing you my PowerPoint program, but now at least you see the images, right?
Yes, we can see everything, and I think it works fine as for now. Yeah.
So good morning, everyone. My name is Tove Fall, and I'm a professor in molecular epidemiology in Uppsala, which is a city just north of Stockholm. So when this pandemic started, I don't have any official role. I'm just a researcher at the university, but I do have quite a lot of knowledge about different types of research and how to use new technology in epidemiological research. Before the pandemic, I was working mostly with diabetes and cardiovascular disease and not with infections. So when the epidemic came to Sweden, I was starting to get very frustrated because the testing capacity was not in focus. So basically, in the initial phase, we did test suspicious cases and contact trace and etc. But when we had community transmission of the SARS-CoV-2 in March, it was said from the authorities that we will not longer test. We will just test whenever it's needed in hospital care, but not for surveillance of the disease or to provide a diagnosis to those that do not have a severe disease. So first I was trying to build some opinion to increase testing, because I realized that testing is really crucial for this disease. We need to both understand the spread of it, and we also need to have people having a diagnosis so that we can do good research on this new disease. And why is then testing and disease surveillance important? Well, both we need to be able to prepare the healthcare system when we have a big increase in transmission. They need to know that so they can prepare their systems. But also, even more important is that if we know about what is happening with the spread, we can also, that can inform policy, that can inform the interventions from the government, and it can also be used to evaluate the effect of the interventions. So I would like to quote the WHO general that says that we can't fight this pandemic blindfolded. We need to know what is actually happening with the spread of the virus in order to be able to fight it in the best way. So after writing a few debate articles and trying to get things going, and I realized that this will not happen in Sweden, I was thinking, what can I do as a scientist in order to actually help the society to improve something? And of course, I can't fund a big testing program in Sweden, but what I could do is to try to find other ways to monitor the spread. I would just like to show you 2 slides first of the testing rates per capita in the Nordic countries, which are colored. You can see that Denmark has been outstanding. I know that Iceland has been doing really well as well, but on this slide, I just showed the neighboring countries to Sweden. And you can see that Sweden, although we had a lot of spread of the virus, we did not ramp up our testing. And that can also be seen on this slide, where this represents the share of the tests that are positive. So this is a measurement of how good you are in testing, and this percentage should go down below 4 or something like that, 4 or 5, then you have appropriate amount of testing. And you can see that Sweden is the blue line. We are way above that still. I think it's slightly better right now, around 10. This is a little bit old slide, but we have been extremely low on testing compared to neighboring countries and also to EU in general using this measure. Okay, so if you can't track the spread with the tests, which you couldn't do in the spring 2020, what can you do? Well, of course, you can look at the hospital trends and the death data, because that will also be an indirect measure of the spread of the virus. But the problem here is that they are lagging behind. So when you have an infection, there will be the incubation period, and then you have symptoms, and then you're not ending up in hospital, usually until like 10 days after onset of symptoms, and death is even later. And then those needs to be reported and processed, and that can take a long time. So just relying on hospital and death data is you are risking to come in very late in the process. Yes, and also another thing is that these measurements is really a measurement of the spread in the older population, not in the young ones, because they are less likely to end up in hospital. So you might miss big outbreaks in younger people if you only look at hospital and death. So what I got interested in is to track symptoms instead of actually testing people. So symptom tracking can be very good. It depends a bit on the disease. If you have specific symptoms, it can be really good. And it's also, if you do it through a smartphone app, it's not so expensive and it's scalable. So you can have many people reporting and it doesn't cost you more. Other systems are not as scalable. So I contacted, when I got this idea, I was not the first one to get this idea. I realized when I Googled, so I find a guy in the UK who had launched a big app together with a health data company called the COVID Symptom Study. It was Professor Tim Spector at King's College London. And I contacted him and said, like, what can we do to import this app to Sweden? Because this was exactly what I was looking for. And he said, well, why don't you talk to Paul Franks in Lund, which is in the south of Sweden? He's already on his way doing this. And then Paul is an old friend of mine. So I contacted him, and then 10 minutes later, we decided to do this as a joint project. And we got all the permissions and all the paperwork going, and we launched this in April 28th in Sweden. And we had a lot of interest in the beginning of the study. So we have now 205,000 participants across Sweden using this app to log symptoms for COVID and donate their data to research. And in total, there are 4.6 million participants in UK, US, and Sweden. So what you do in the app, you spend about a minute per day just logging whether you have any, if you feel healthy or if you have any symptoms. And based on this, we have developed a prediction model to estimate the prevalence of COVID in Sweden in every region at every day. And we communicate all these results to the public and to health authorities for a weekly report, and to the public every day on our dashboard. So if you look at the trends, you can see that the blue line here is our estimated prevalence from the app. The red one is the testing data. And you can see that here in the spring, we didn't really test. That was not launched until in June. So here, we think that our estimate is much better. And then you can see here, there's a big hump here, which was not reflected in the testing. And here we had a problem with the app because there was this other common cold virus going on. So that influenced our decisions. Our algorithm couldn't really separate this common cold from COVID in a perfect way. So we're working on trying to make that better. So just to sum up on this, I think that we collated a lot of data. We're able now to understand much more about COVID from our data and from the UK data, and it's been a really great thing to do. We have several municipalities that are using our data. It's much quicker. We always report the day after, while the testing data is not available to the commune, the level, the municipalities, until about 10 days after the actual week. So they really like that our data is very quick. It's not as reliable as the testing data nowadays. Now we have a lot of testing, but it's useful for them. So that's very encouraging. And then during the summer, I started to think that, well, you should be able to add even more data to this. Why if we can combine different layers of data? If we can see how many people are calling the nurses hotline, which is called 1177, where you can get health advice, because we know if you call them and you have a fever, that could be an indication, if many people do that in the area, that we have an increased transmission. And what about if we can map ambulance calls? We can also combine it with wastewater analysis, with the testing data, and also other information about socioeconomy and mobility and so on. So we're doing this now in the Crush COVID project in Uppsala. So this is a very regional project. We're collaborating closely with the health authorities in Uppsala region. And our first study was quite interesting, actually. We found that testing rates are very heterogeneous across the region. So all these areas are postal code areas. And the more you test, the more red an area is on this map. And you can see to the left that up to October, there were only 4 testing stations in this county. And you can see that the testing is concentrated to areas that are close to these stations. So we have a lot of like white spots on the map. We can also see on the map to the right other white spots. And these are socioeconomically deprived areas where we know there's a lot of spread of disease, but people don't get tested. So based on our results, the region have now a more focused strategy where part of this is to send a mobile test team to those areas that need it the most. We have had quite a good effect of this mobile test station, and we're now developing this. So this has been very rewarding that we can closely collaborate between the scientists and the health authority locally in Uppsala, and this has been really rewarding for both parties. So I would say, to sum up from my perspective as a scientist, during a crisis is that we really need to collaborate. This is key. So one person or one entity, they don't have all the competence or all the tools needed to work us out of the crisis. And I think you should really trust the scientists to formulate good questions and spend their money wisely. I think we need to have scientists need to have some kind of budget to do these crisis research. That has been key in both these projects, that I had some funding that I could quickly spend on setting these projects up. And then in Sweden, I don't really know how it's been in other countries, but it's been extremely difficult to be in media about COVID. So the debate is very polarized, it's politicized, and it's if you appear on TV, on Twitter the day after, you can have everything from comments on your looks and to every single word you said. And a lot of research findings are interpreted directly from a political perspective. So that's quite tough to be a scientist and trying to communicate the results in this crisis. And another thing I have been lacking in Sweden is that we don't have a really good forum to meet the health authorities. So there's a lot of academics in Sweden that have had very good ideas and very thoughtful ideas, and also knowledge about things like elderly care. So we had a lot of problems with a lot of people dying in elderly care, and we also have a lot of experts in elderly care, but they weren't invited to discussions on how to form the policies. So I think a forum for scientists to meet the decision makers, maybe every week, would have been great to exchange ideas and discuss these very difficult topics. I mean, there's no easy solutions to a crisis, but I think we need to collaborate better to be able to come up with the best solution. And of course, not only nationally, but also internationally. I mean, there's a lot of good examples of countries that have succeeded much better than Sweden in this fight. So I think we should collaborate and learn from each other. That was it from me, and I will stop sharing.
Okay, thank you, Professor Fall. Thank you so much for your elaboration. I think Sweden has been receiving a lot of attention in international media for its response. I would like to give the floor now to our last speaker, Professor Runólfur Pálsson in Iceland.
Good afternoon, everyone. Can you see my slides?
We can. They're not full screen, though.
No, they are.
Now they are. Yes, thank you very much.
Thank you very much. And thank you for inviting me to participate in this session. And I'm really delighted. It's been very interesting discussion. Now, I'm going to discuss the Icelandic experience in sort of managing the pandemic. Now, Iceland, as you know, is an island. And there are a few things that we need to bear in mind. First of all, the population is very small, as I'm sure many of you know, only 368,000 people. Now, the majority of these people, 2/3, live in the sort of greater Reykjavik area. And there's another populated area in the northern part of the country, Akureyri. And from the beginning, the first case was confirmed in Iceland on at the end of February last year. From the beginning, the government placed a lot of emphasis on healthcare-related issues at the expense of social and economic factors. And the reason is that our healthcare system, particularly hospitals, are quite delicate. I mean, we have only 2 major hospitals, one in the Reykjavik area, the University Hospital, and one in Akureyri. And we are a bit short of hospital beds for emergencies. So if the outbreak would go rampant, I mean, we were afraid, of course, that that would really deplete our resources. Now, there are 2 issues also I would like to mention. One is that tourism is a major industry in Iceland. So closing the borders, of course, would have a major impact. And the second is that we rely a lot on imported labor, even on a seasonal basis. So we still need to import these people. And of course, they can bring the virus, I mean, if they are infected. So, I mean, this is another concern that we have to deal with. Now, the strategies that have been applied mostly, well, we have this National Pandemic Preparedness Plan that was led by the Department of Civil Protection and the Directorate of Health together with the Chief Epidemiologist, the Directorate of Health as a leader of this. Now, from the beginning, we had emphasis on social distancing, restrictions on gatherings, and personal protection measures, and extensive diagnostic testing right from the beginning that was carried out by the primary healthcare services, and quickly in an automatic fashion, really. Comprehensive contact tracing from the start, and then eventually robust border control measures. I mean, we closed the borders for a while during the first wave, and then in June, the borders were opened again, and we started testing every visitor. And for the past, well, since September, we've been doing 2 tests, 2 PCR tests with a 5-day quarantine interval in between. And then a major emphasis on use of health information technology solutions to support the management strategies. Now, this is the so-called TRIO. We have the Director of Health and the Chief of Police for the civil protection services, and here is the Chief Epidemiologist. And they had very frequent press meetings, mostly on a daily basis, providing information. And then we had an information source, covid.is, providing updates regularly. Now, we developed a contact tracing app for mobile or for smartphones, and then also had a big workforce doing the contact tracing. Now, in terms of the care of individuals that were diagnosed with COVID-19, the University Hospital organized the care of patients across the country. Of course, we are small, we have a small population, but this could also, the same strategy could be used regionally in larger countries and populations. Now, in the clinic of the University Hospital, we closely monitored infected patients in isolation using telehealth services, and then for symptom monitoring, risk assessment, and psychological support. And patients with severe or worsening symptoms, or those who were considered at high risk, they were referred to the COVID outpatient clinic for evaluation. And then we provided hotel accommodation for individuals who were unable to isolate themselves at home. Now, this is just a telehealth center, and we had up to 100 people working in the telehealth service at the peak of the outbreaks. We also developed a smartphone application for clinical monitoring in collaboration with Sidekick Health, which is an IT company, and could use that to interact with patients. Now, these are photographs from the COVID outpatient clinic. And we basically, this was an office building on the hospital campus, and we quickly changed it into a clinic. And what was useful is that there are doors for each room here that we use for examination, so patients could enter from the outside. And this, of course, having this clinic for urgent care allowed us to divert patients away from the emergency ward and from the hospital building. And we could also, by intervening early in the course, when we identified risk factors or severe symptoms through the telehealth services, we could invite or bring people for evaluation. And sometimes individuals came for several days on a daily basis, and they were given intravenous fluids and so on. So we cared for a number of patients there, and in the hope that this would lead to reduced hospital admissions. And we could monitor using iPads what was happening in each of the examining rooms. And we also did a lot of sample collections for hospital staff, for instance, that we also had in relation to this clinic. Another important factor in Iceland, and this brings us to the scientific aspect as well in terms of managing the pandemic, was a contribution from the human genomics company Decode Genetics, which is one of the leading sort of institutions in the world in human genomics and genetics. They contributed to diagnostic testing early on when the virology lab at the University Hospital sort of was exhausted. In terms of the resources, at Decode, we also had sequencing of the RNA genome of every viral isolate performed. And then there was extensive research efforts in collaboration with scientists at the University Hospital. Now, the statistical information was updated every day on the website covid.is, and this sort of gives you an idea of sort of the numbers that we had. Here you have the total figures from the beginning. Well, this is the full year because this is at the end of February this year. So there's 1 year of experience here. So we had a little over 6,000 confirmed cases, and here's the number of samples: domestic 278,000, 45,000 quarantines completed, border samples. You can see here 148,000 first-time screening, and then 75,000 second screening at the border. We had 327 hospital admissions and 53 admissions only to the emergency ward. So many of the patients who were admitted to hospital came through the clinic. And here you can see a hospitalization rate, which was 5.4%. And this is not as low as you might expect, but you have to bear in mind that we did have one real downside in managing the pandemic. Is we had an outbreak at a geriatric unit of the University Hospital, where we had about 50 patients becoming infected, and we had 17 deaths. So that influenced heavily sort of our outcomes, but still the hospitalization rate was 5.4%. Including those patients that I mentioned. 0.9% required ICU care, and case fatality rate was 0.5%. You also have to take into consideration that we did a lot of testing. I mean, we had great access to testing with a very rapid turnaround time for the PCR test, only about 2 hours, 2 or 3 hours. So that has to be taken into consideration. Now here you can see the waves that we had. The first wave here, February and March, and then we enjoyed a good period during the summer. A small wave though, because people became complacent, and then we had a large wave here that included this outbreak at the University Hospital in the fall. The orange line is the border screening tests, and you can see here in January and in particular, we had more positive tests at the borders than we had domestically. And now people are really back to sort of close to normal life, although we do have restrictions, and we still are doing this double border screening. So things have not really gotten back to normal yet. Now, we published several papers reporting our experience. I'm sorry, here is one in the Journal of Internal Medicine, another one in the British Medical Journal describing the clinical spectrum of all the cases up to that point in Iceland, mostly during the first wave. And we noted that about 70%, 67%, I believe, had very mild symptoms throughout, but many of them did not have a fever. I mean, the most common symptoms were myalgias or muscle aches, headache, and a non-productive cough. So that led us to believe that it's difficult to rely on symptoms solely. We also, through collaboration with Decode Genetics, reported on the antibody levels in the Icelandic population, and we found that only 56% of those who had been diagnosed through a PCR test only 56% of those who had antibodies against the coronavirus had been diagnosed with a PCR test. So 44% had never been diagnosed but still had antibodies, and many of them were probably asymptomatic or had very little symptoms. At least with easy access to testing, they did not request having tests performed. Now, in terms of looking at the past year, what we have learned is that key strategies for success in our view is right balance between science and politics. The government relied heavily on the chief epidemiologist and on Icelandic leading health professionals and scientists. And of course, through the years, been a debate about many of the decisions that have been made. But overall, people realized that we had to protect the healthcare system. I mean, if we would have had a huge outbreak here in Iceland, the hospitals could not have dealt with it. Now, timely implementation of stringent mitigating measures, I think, were successful. Extensive collaborative efforts for rapid creation of innovations, and particularly collaborations between scientists, hospital staff, and sort of public health professionals and so on. Optimizing the use of digital healthcare solutions proved to be very helpful. Now, effective public information and education. I think these press conferences on a daily basis, the COVID.is, very informative web page, delivering updates was helpful. And then delivery of medical care in the right place at the right time as well. But we also have to bear in mind that the social and economic downsides, I mean, should not be underestimated. And unfortunately, we do not yet have enough information on that, but clearly there will be constantly, there's unemployment has increased, and the government has had to deliver economic packages, supporting unemployed people, subsidies for businesses, for instance, in the tourism and other businesses that had a major loss of revenues. But time will tell. I strongly believe that it still would have been worse if we had lost control of the pandemic. Thank you very much.
Okay, thank you very much, Professor Pálsson. That was very interesting. I would like to remind the audience real quick that you can use the Q&A function on the bottom of the screen to post your questions, and I will direct them to the speakers. I also want to say that we might not have the time to answer all the questions, but we will do our very best. Okay, diving straight in to the first question. I hope everyone's on board. It's from Julian Tucker. He says, thank you very much for your insightful and thought-stimulating comments. Could the speakers elaborate a little on the Nordic and Taiwanese experiences of responding to or managing misinformation in the context of the pandemic? Would anyone like to go first? No one?
Well, I'm not exactly sure what to address in this respect. I mean, what maybe you could explain a little bit what exactly the question is about? Missed information?
Yes, it's about misinformation, and I guess it also hinges upon fake news, things that spread very fast on the internet.
Misleading information, maybe. Yeah, I see.
Yeah, and I think that's what Professor Fall already mentioned during her presentation.
Absolutely.
So, is there anything
experience from the United States? I think the whole world does, and that had severe consequences there. I don't think we in Iceland we really did not experience that, and it's not, at least as far as I know.
What about Norway? Maybe Therese.
Yeah, sure. Here in Norway, I followed the debate, and it's not as much about misleading information, but now, of course, with the vaccines rolling out, you have the AstraZeneca vaccine and the decision not to use that on people over 65. Created a bit of conundrum in certain forums and comments, and I know that MSB, the Authority for Contingency and Crisis Management Planning, they are on the case in Sweden anyway to educate healthcare personnel in terms of, and regions in terms of actually giving out information to people in the regions and health districts. In Norway, it's been fairly, the debate is most about lack of vaccines and the distribution of vaccines. So it's not so much about misleading information. Here's been precautionary principle first, and we have to do what we can to reopen the society, but we don't want to risk any lives, right?
Thank you very much. Professor Dr. Chun-Chien Kuo, do you have anything to add on Taiwan? You already answered the question, but maybe for the entire audience. And you're muted, actually.
In Taiwan, I think the misinformation, the government is trying very hard to, through the daily conference, the media conference about COVID-19, to clarify some information and make all the information be more transparent to all the people in Taiwan. Of course, there are some misleading information about one, and the government try to clarify their point of view. But most likely, people in Taiwan, of course, 50% trust, 50% distrust. But anyway, as the speakers clarify, providing more additional information or more transparent information, this misinformation central situation will improve a little bit. That's the case in Taiwan. Thank you.
Very similar experience in Iceland. I mean, of course, things have been introduced through the year, but usually it's been immediately reacted to by the officials.
Thank you very much. Professor Fall, would you like to add anything, or?
No, I just think correct information is, of course, crucial, and developing this crisis. I mean, the knowledge about this virus has also developed over time and about the effect of different interventions. And it's interesting to see how the information has been received, communicated in countries. So as an example, wearing face masks have not been enforced in Sweden and not really encouraged. So I haven't seen any survey, but when I talk to people around me, they are very skeptical. But I assume that in other countries, the attitude is different. So information is really affect how we follow recommendations and what precautions we take.
Okay, before I go over to the other two questions that we received, I would like to relate to this topic. All of you mentioned the digitalization of healthcare in this very process. How do you think this is going to move forward? I mean, it seems that there's been a speed up in trying to get more digital healthcare out there now that we don't want to interact with people unnecessarily due to social distancing measures. Were there any privacy concerns when you started introducing those apps, or when you collected data? Is there anything that you came across as controversial or?
Yeah, with the Symptom app, we really made sure to design it to be as least intrusive as possible. So the participants are only sharing their postal code. They are not sharing the personal number, which is otherwise the key identifier in Sweden. So there were a lot of questions around the privacy, and we had to really scale it down to use a minimum of variables. And of course, this limits also what we can do. I would love to link our data to other sources, but we can't. So I think this needs to be, done in communication with different stakeholders. But I get the impression now in Sweden that it's soon so hard to make research, so we're lagging behind. It's so tricky. You need all this paperwork done, which sometimes it doesn't feel like it increases the security or integrity or quality. It's just, needs to go through. So I think we need to make it easy and safe to do research, and also with, for example, the contact tracing, we can save lives by doing good contact tracing. So of course we should have systems where the doctors can use to save those lives. It's really important. But at the moment in Sweden, I find that the legal framework is hindering a lot of those efforts.
Would anyone else like to add anything?
Well, yeah, in Iceland, we took a number of steps forward actually in terms of digitalization of healthcare and the use of health information technology. Now, this was all overseen, all the developments were overseen by the respective authorities, including the Personal Protection Agency that you have here. So we had to get all these applications approved, but this is already having an impact on how we just practice and the way we see things in the future. So, but of course you have to have the proper equipment. I mean, you cannot, in terms of doing this in a proper and regulated fashion. So that's where we stand now. I mean, in terms of bringing this into the healthcare system in a much greater way. But it's I'm enthusiastic about this, and I think it's going to increase our efficiency in the future and hopefully increase the quality of care as well.
Indeed, thank you very much. Dr. Chun-Chien Kuo or Therese, would you like to add anything?
I think there's the controversial issue between the how applying the digital service in medical and privacy. In Taiwan, this time for example, we are tracking the contact people information, and in my point of view, against to prevent the virus from spreading, some necessary digital, privacy being violation is necessary. But in the future, I'm very optimistic about the whole science improvement using the digital technology in the medical non-face-to-face service. But in terms of privacy, unless it's necessary, for example, this time it's crisis, and the government they should have allowed to violate this personal privacy a little bit in order to save the whole country or the whole from the disease. But in the future, I think more laws and more restrictions should be applied on government adopting this digital technology and in monitoring people's movement or activities, something like that. That's my answer. Thank you.
In Norway, they launched relatively early a tracing app called Smittestopp, and it was relatively early on deemed as not good for personal integrity to so to speak. So they had to do a rollback of the tracing app, and they developed this and in order to fit with regulations, existing regulations on GDPR, and launched it again during the fall. And now over 1 million Norwegian has actually downloaded the app, and it's this Bluetooth that connects with other Smittestopp users. Who, if they have been tested positive, they log on with their electronic ID to register whether they have been tested positive. So you get an update if you've been close to a person who actually have been tested positive. So this is a good way if you're commuting or because it works. And people who have developed symptoms but don't have anyone in their immediate cohort that's been tested positive, they know, okay, I was in a store or whatever, and someone there sneezed, or I don't know, but it's apparently it's working.
If I may add, I think in the Nordic countries, we all have pretty stringent personal protection laws and regulations, and which is very important. And in Iceland, I mean, we've had to deal with this in healthcare and research for almost 2 decades now, largely because of the initiatives of Decoded Genetics, the genomics company that I introduced. Now, one thing that we also have to bear in mind, and I think at all times, is that we cannot go too far with personal protection issues, because we cannot risk losing lives of people because of personal protection issues, even if those are very important.
Indeed, indeed. Thank you very much for your answers. I would like to jump to the next question by Victor Nilsson, who says, I wonder that something many people miss about the Swedish model is that we could not close or prevent freedom of movement due to our constitution. What is your thought about the governments or politicians walking over the constitution? Maybe Tove Fall might, or do you want to tackle this one?
Yeah, I am not legal specialist, especially not on the constitution. I have collaborated with Mark Klamberg, though, who's a specialist in international law, and I think that I would like to see a good investigation on what is possible and what is not possible, because there are different opinions about that, especially in terms of closing down stores, etc. So I think if the government really wanted to, they could have proposed to the parliament restrictions or more restrictive actions, and the laws could have been changed. But I mean, of course, the constitution takes longer time to, but the smittskyddslagen is quite strong, actually, what we can do to protect people. So I think that it was not only for lack of possibility, it was also sometimes a lack of willingness to do. So that's my impression. But of course, I'm not a legal specialist.
Can I second Tove here? Because that is exactly my impression too. Because both the Ordningslagen and the Infection Control Act, I didn't find a good word for Ordningslagen. According to some professors in law, and this is the thing with law, it's how you interpret the wording in it, and there can be so many meanings, but there are seemingly a lot of room for the Swedish government to at least during the first wave, to have implemented more stringent measures to prevent that rapid spread of the infection. in society. And so I fully agree with Tove here, actually.
Yeah, I agree as well. I mean, the Constitution is obviously very important and should be honored. But you know, if you basically have a national emergency that jeopardizes the lives of you know, large proportion of the population, I mean, then you know, you have to take the necessary steps, you know, irrespective of what the Constitution says. I mean, I think everybody understands that. So I think it boils down to, I mean, when do you declare a national emergency that warrants this, you know?
Can I comment on that too? Because this was a point that I missed during my very talkative presentation, and it was that one thing we are assessing is also the historical experiences of crisis in these countries. What makes them differ in making these tough decisions and expecting their citizens to actually accept these measures? And maybe in Norway, who experienced occupation during the Second World War, they never get tired of talking about that. But it's also about July 22nd, the terror in Oslo, but also experiences that we shared as both Norwegians, Swedes, Finns, and in the Nordic society. Did these crises that we shared, but also experienced as single states, did they create spinal reactions? That this is how we define a national crisis, and this is about also lifting an issue up to a national level instead of honoring the local autonomy principle. And that's a huge difference, I also believe, between Sweden and Norway, that they actually lifted the issue pretty early up on national level and said, okay, we're not going to tolerate this. But we also have to consider, do we really think that all the people who works in the hospitals now in Sweden, for example, who works with this crisis agreement, and is that according to their rights? How do we deem, what is the trade-off here? How do we deem which right is more important than the other? Is it really right that that they have to, the healthcare personnel and the old generation, the old people really have to be the ones who have taken the most of the burden, for the working population to be the one whose freedoms should be secured? So I know this may sound controversial, but there are a lot of things to think about. And when it comes to law, I'm not a lawyer. That's not my field, but we have to recognize that there are so many ways to interpret these issues, actually.
Thank you so much. Dr. Chun-Chien Kuo, would you like to add anything to this? Or?
No, not.
Okay.
I'm not familiar with the Swedish model, so.
Okay. Great. We are out of time now, unfortunately. We do have one more question. I would like to dismiss the question for now because we ran out of time. I would like to thank all of you so much for your participation. This was a very interesting, very insightful discussion that we had. And I hope that we can have another session in the future, because I think there are so many questions that have not been answered and that we are still trying to figure out as we continue to live the pandemic. So thanks to Professor Pálsson, Professor Fall, Dr. Chun-Chien Kuo, and Therese Sefton. Today, we're very happy to have you. And I wish you all a good day and hope to see you soon.
Thank you.
Bye-bye.
Bye-bye.